welcome everybody. Today's lecture will be on an unusual case, but sometimes when you go over unusual cases, you learn a lot about normal cases, and you get an understanding of pathology from abnormal cases. So we'll talk about synovial cysts of the, thanks Doug, synovial cysts of the spine. And we're really lucky today because we have a radiologist, orthopedic surgeon, chiropractor, pathologist, general surgeon, and an orthopedic surgeon from India. So this is an incredible group. This is a wonderful group. Okay, so we'll start first with a simple case, and then we'll get into the current case, which is complex. So this is a simple case. This is a 21-year-old man who had right thigh pain that radiated to his lateral thigh and knee. And he's had this for 6 weeks. He's a healthy man, 21, very robust. He's a power lifter, so he's like 225s, all muscle. So if a man came to you, Doug, with those complaints, 21-year-old power lifter, thigh pain to his knee, what would you do? Doug?
I'd probably work him up for a disc disease.
Okay. You give him some medicine or no?
After a thorough and comprehensive physical examination, which precluded any deficits, I would probably image him first with an X-ray.
His X-rays are normal.
And then I'd probably recommend that he try some Anti-Inflammatories and activity modification.
Okay.
A little bit of rest and come back and see me in about 3 or 4 weeks.
Okay, he did that. He took a couple ibuprofens. When it comes to rest, no way, Jose. He's lifting weights.
He's going to go see a chiropractor then, probably.
Okay.
And I would just, what do you hope to? I know it's the first line, and it probably is the right thing, but what do you expect to see? I mean, the probability I think of seeing something wrong in a 21-year-old on an X-ray, with essentially ridiculous symptoms, right?
It's almost zero.
I think there are two plays. The first play is if it's a screening exam. I always tell people you don't see a cardiologist without an EKG. You don't see an orthopedist without an X-ray. I mean, first go around. Sure, I might. If I was in a doc in the box place or something, I might say you got a lumbar strain. But if I was going to start to work him up, first thing they would get. No, I don't feel terribly strong that an X-ray is going to show something, but.
It's what we do as orthopedic surgeons.
People expect to have an MRI almost no matter what. I didn't even get an X-ray. We're right to an MRI. And,
I'm seeing that more and more. Especially now that I'm working in the outpatient office, where a patient will. Now, actually, again, in an outpatient office, I'm seeing the MRI, and there's nothing the patient's had. Now, that's not to say in the orthopedist or the chiropractor's office or whoever's office they're getting an X-ray that I just don't have access to. But a lot of times, the first line I see is the MRI.
People expect imaging.
That's patients' expectation.
Yeah, they expect imaging, and they get very angry when they don't get imaging or medicine.
And they go to someone else and say, "Well, he got an MRI right away, and it showed that I've got,
Right now, the opposite's happening. What you're talking about is I had a patient from Aetna who had horrible sciatica. I mean, this miserable, couldn't walk, and Aetna's like, "We're not paying for it." And like, why? Well, they didn't have any physical therapy yet. I was like, "This person can't walk." And she goes, "Well, sorry, these are the rules. Needs 3 months of physical therapy." So the patient just went to the ER and just got it through the hospital. But Aetna refused to pay for it, which is it's the other end of the spectrum,
right?
What
you do for that? You ask who the medical director is. You tell him I'm a physician and I want to speak to the physician that's making this decision. And if he denies it, you say, "Where are you licensed? I'm reporting you to the state medical board."
Yeah, I should.
People back off on that shit because otherwise you're just dealing with someone who's a mid-level provider who's got a little checklist in front of him.
Right.
Back pain, doesn't have cancer, physical therapy.
That doctor was an OBGYN doctor who talked to me.
Okay.
Well, that's I know.
You speak doctor to doctor, and you just say no problem, but I don't agree with you.
They don't want to. They don't even. This is a different topic.
Make it painful for you because you don't want to make 1,500 phone calls, and they just grind you down.
Well, the patient's the one who suffers in the end. I mean, this poor woman can't walk. Anyway, all right. So he fails it. So he has the MRI. So
All right, so we've got a sagittal MRI of the lumbar spine. It's a T2 weighted signal series with the CSF as being bright. And at the L3, L4 level, you can see that the normal bright signal, like the L2, L3 disc, if you look at it, you can see there's very nice water signal there in the disc, the sort of the nucleus pulposa water. And then if you go down now to the 3-4 disc, you can see that you have lost that. So the disc is what I would call desiccated. It's a little bit lost in height. The space is narrow. And then posteriorly in the spinal canal, where the nice circle is, that you can see that there is some abnormal signal there. Now it's bright, so that would make me think of water. But there's also probably a disc protrusion that I think shows a little bit better, maybe on the other slice. Where that disc is coming out. So to me, what a disc protrusion is where the posterior ligament has, the posterior ligament, the annulus fibrosus has torn, and that gel-like nucleus pulposa is going through it. So it's more than just a disc bulge. It's some nucleus pulposa that's out there in the spinal canal.
You know what usually happens, just because I'm a surgeon?
Yeah.
Is it's not capsule versus pulposus, is this stuff
transition.
right. Yeah, it's versus transition, and this stuff right here is all connected, and a piece just comes out, and sometimes it's loose, and sometimes it's still connected from where it came from.
Like a door hinge.
Yeah, exactly, like a door. Yeah, like a door hinge.
Desiccated piece of junk that
And a
gets,
lot of times it's a couple pieces. So there's like a rent, and then a couple pieces of annulus comes out. Okay, so here's these axial cuts.
So the axial cut, again, it's fluid signal, and this is probably a fat. Well, I can't tell if it's such a high. Anyways, fluid signal, and it looks like it is outside of the dural sac, and it's compressing the dural sac up against between this cyst and between this fluid and between the thickened ligament. So it's.
So what is this thing? This black line?
That black line is an interface of some sort between whatever this fluid is and the dural sac. It's probably dural sac.
Wait a minute, isn't this dural sac right here? That's dural sac, right? What is this? You backed off on the word cyst because Christian's here. Christian, can you tell us what's a cyst?
Cyst is just a cavity with a lining, and it can be
With a lining.
with various types of linings.
Okay.
I don't want to get ahead of ourselves with what I'm going to
Right.
show you here, but you get all different kinds of cysts.
Right. But the definition would be a cavity with a lining.
Right.
So, okay.
Did you suspend steroid use in this patient from?
Oh yeah. This guy uses steroids. If he's not currently using, he's used it. I mean, he's huge. You don't
Okay.
get that big. Very rare to get that big without steroids.
So maybe a screening X-ray, you might see that the guy has a compression fracture or something too.
Yeah.
If he's a big steroid.
You get fracture, subluxation, scoliosis. It gives you info. All right. So I just want to go over facet. So this guy has a what I think is a facet cyst, and it's an outpouching of the capsule. Doug? What's the most common cyst that you see in orthopedics?
Usually of a large articular joint. The larger the articular joint, the more chance. So probably knee, Baker's cyst.
Baker's cyst from the knee, right?
Wrist,
Which comes off the gastroc and semimembranosus, right? It's like an outpouching of the joint.
It's an outpouching of the joint.
Yeah. And
Rarely is it symptomatic.
the cyst itself.
Yeah, even more rarely is it operated on. It usually has to do with the meniscal tear, and what happens is the capsule pops out through the meniscal tear. And so most people just address it arthroscopically from the front by cleaning up the meniscus, and it's got like a one-way valve in it, and what you do is you just try to open up the mouth of the cyst, and then the Baker's cyst decompresses into the knee, and you're done with it.
So why does the joint? I wonder, why does the joint pop out like that? Is it a weakness of the joint itself, or is it?
No, I think it's inflammation and degeneration, and it's increased synovial pressure, and basically that's the weak.
So it's like an effusion, and it just goes through that. Okay.
And I see, I've seen on teenagers, what I call the synovial recess between semitendinosus, semimembranosus back there, as young as 14. I mean, there's a sliver of fluid. It's not round. It's just a crescent of, but it's, extension of synovium out there. So even at that young.
So just to review the spinal canal. The spinal canal has different shapes at every level. The foramen magnum, the C2, somewhat triangular at C6. In the lumbar spine, it's somewhat round. It gets a little bit triangular at L5, and it's big in the lumbar spine. And then within the spinal canal are nerve roots. Spinal cord ends at L1, L2, 85% of people, and then below that is a bunch of nerve roots. So when the cysts compress into the spinal canal, it's hitting these roots, as we all know. And each level has its own nerve root. And the spinal canal should have an area, now this is from Rene Louis' work, which may not be like peer-reviewed. It's from his book. But I think it's real. And the mean AP diameter is maybe 16, 15, 15 in the lumbar spine. Cervical spine 16, 14, 13, 13. And there's a range, obviously. And some of these ranges are really small, 9, 11, 10, 13. So, as a radiologist, what do you say? I mean, you guys use words and use your eyes. You look at things and use words, and we read your words. And You know, some radiologists say small caliber diameter spinal canal. Some radiologists say congenital stenosis. Some radiologists say developmentally small spinal canal. Some radiologists say little excessive room for the spinal cord. What words do you use? If you see a
I try and use
9 mm canal.
I would say probably a congenitally.
Congenital.
And it's usually due to the pedicles, the length of the
Short pedicles.
Yeah.
Okay. So, thing is, I'm like I'm a weirdo when it comes to these things, but I hate to use the word congenital because it means you're born like that, and I think that these people are not born like that. I think they're born with like normal canal, but as they evolve in their lives until the age of 12 or so, that's that evolution from 0 to 12 is when they develop that small spinal canal.
Isn't it acquired then?
So
Rather than congenital?
I prefer the word developmental. So we used to, and this problem is in hips too. We used to always say congenital dysplasia, and then they changed the word to developmental dysplasia because the child was normal when he was born, and when the pediatrician checked the hips, he or she did a good job. The hips were normal, but they developed from the age of 0 to 2 years into that problem. So for us, that's what I use, but it's not a big deal. It's just a word. So let's say you compress the spinal canal very tight there, you can get saddle anesthesia or cauda equina syndrome, which is a serious emergency. And saddle anesthesia is if you sit on this saddle, if you're buck naked and sit on the saddle and there's pain on it, and then you stand up and look where the pain is, that's where the people get numb. So it's saddle anesthesia. And they can get urinary retention, and sometimes they just dribble, they don't realize there's a problem, but if you do an ultrasound, there's a very large bladder. So here's, these are just, let's just keep moving. These are just other synovial cysts. So normally I decompress these people with this unilateral laminectomy, bilateral decompression through this porthole, through the microscope. I can decompress both sides of the spinal canal. This is the standard laminectomy approach. And you do this, see, this is your porthole where you open it up, and then by going across the table, you can decompress both sides of the spinal canal from a unilateral laminectomy. So in that manner, you only cut half of the muscles on one side. And because the microscopes now are very agile, and because the light sources are very bright, you can do the surgery in this manner. You don't need the big incisions. So this is what it looks like afterwards. You can see there's only one side has been opened and both sides are decompressed. And we're kind of running out of time a little bit. I was going to go over video, but we'll do that later. Okay, so this is case number 2 now. So any questions up to this point? So we're talking about synovial cysts. Case number 2. This is the case we're going to talk about. 65-year-old man with low back pain for 2 to 3 months. It's not acute. It's his left buttock and lower back. It's worse with activity. It's better when he sits. He's a very healthy guy. He has gout. He had an episode of podagra, but that was it. He has diabetes, high cholesterol. He's married, 3 children. He works from home as a hotel executive recruiter. Very, very nice, pleasant, intelligent man.
So he's not that healthy.
Well, he's a little bit overweight, 5 feet 8 inches, 240 pounds. He probably has what do they call it? Metabolic X or
Right. Syndrome X.
syndrome X? Yeah, something like metabolic syndrome. But other than that, he's good.
He's got a lot of calcification of his aorta. And I always tell people this when I see them. They're always dumbfounded by it. They say,
Right.
"My doctor never told me that." I'm like, "Well, you do."
Right.
They're like, "What do I?" And I'm like, "Go see your doctor." But I'm just telling you,
Right. What do you say? I say you have hardening of the arteries.
hardening of
It's
the
gonna be a problem.
arteries, yeah, and it depends on who they are, but sometimes I lay into them because they're big fat people that smoke, and they're like a ticking time bomb.
Recording this here.
Yeah,
Okay.
big fat people who smoke.
Yeah.
And they have a lot of risk factors.
High blood pressure, right?
And,
Yeah, I say it too.
And so, I say, this is not what I treat, but this is an incidental finding. You have
Right.
hardening of the arteries, and this is a systemic problem that affects your head.
Right.
You get a stroke, it affects your heart, you get a heart attack.
Right.
A lot of times, people have sexual issues
Right.
in the lower aortic.
Yeah, I have the same.
abdominal
I have the same
aorta.
speech. Could
They
be going
have
on.
peripheral vascular disease, and they lose toes, but just so this is something that I would see on a screening X-ray, also. And I always tell people about it. I tell them as much as I can about their
You have to tell them.
findings,
Yeah.
even though they're because many times their PCPs don't tell them.
Well, you only get 10 minutes
And
per
or, you
patient.
know, they
You
don't,
know.
a lot of the PCPs don't even look at the x-rays, they sort of look at the report, so I always look at all my studies. And,
Yeah, you talk
I'm not
to-
sure if I make a difference one
Right.
way.
Well, you tell the least of your worries is probably the orthopedic problem.
Right,
You
right.
know, so we got some, you know.
Your lumbar spine is fine.
Right.
Okay. So let's just
Where's
say,
the normal lordosis in that spine?
not so much lordosis. Yeah, pretty straight, and so it's not that much.
Is it disease related?
You'll see in 1 second. So anything else, Adam, that you want to point out for the X-ray?
There is some degenerative disc disease at L4-5.
See the osteophyte there.
Yeah, and it's narrowed, and there's some facet arthropathy a little bit. There's an increased density.
Maybe a
there.
sclerotic. Yeah.
Yeah.
Increased density. Okay. So let's go straight to the MRI. So what do you see on the MRI, Adam?
So there's a mass of tissue posterior from L2 down to L3-4.
Mm-hmm.
And it looks posterior.
Mm-hmm.
I can't tell from these if it's left and right. It looks a little bit on the left, actually, from the bottom center tiny image, very, very down low in the
Yeah.
gap.
Yeah.
So it's a little bit on the left.
I'm gonna show you more images.
Okay, so
Look at this. What's this black stuff and what's this white stuff?
well, it's all very heterogeneous. If you notice from this one, the white is not as white as the CSF. As like on the previous one, it was much cleaner
Yeah.
in its signal. So this is much more heterogeneous, and so it is not either just simple fluid.
Mm-hmm.
You know, again, from this, the disc looked better. In fact, on the previous one, you know, the guy had what looked like a disc protrusion also.
Yeah.
Whereas this guy's disc, there's some bulging, you know, 4-5.
He's got some bulging there.
And they're desiccated, but the disc at 2-3 looks great, and the disc at 3-4 really doesn't look very bad.
At the disease levels, right?
Yeah, so,
So it's not from the discs you're thinking.
yeah, it's not from the discs.
Okay. So how about this one?
So the image on the left is a T1 weighted image, and there you can tell because the CSF is black. So
CSF.
it's bright again on T1 and T2. That stuff is bright, and so what is bright on both is fat is a thing that's bright on both. Blood is another thing that's bright on both, or can be bright on both depending on the age. And so you know we just don't know right at this point. We just have some
Okay.
heterogeneous tissue back there. We
Here's
don't know.
another image for you.
All right, so then the image on the left again is T1 from looking at the CSF. You can see the CSF is black, so it's bright and a mixed signal. And
And this is dark.
hemorrhagic stuff or fatty stuff, but you know, again, could there be a tumor that has bled or something? We just don't know.
Okay. Here's a L3, L4 disc space.
So on the right, it looks well. I can't tell.
By the way, I'm
From
gonna
this-
tell you something funny. I took this with my iPhone, and that's my finger, and this is in the office, and then I emailed it to myself, and then cut, pasted, and put it in PowerPoint. Just to show you, it's kind of interesting how we do things these days. But go ahead.
Yeah, I don't know what you know. I
Here's a
can't tell.
mass.
Is that the pathology? Or
That's
is
the
that-
mass right here.
That's the mass. So again, it's heterogeneous. It's bright and dark. And
Okay.
It's very central in the spinal canal. It really is causing very significant spinal canal stenosis.
Okay.
And I can't tell if it's coming from a facet or a disc. Or
Okay.
where,
How
or
about-
if it's primary?
How about this level? You see the cyst, right?
Yeah, so there we can see that it's you know, the mass, I would think, because of its
Mass, yeah.
heterogeneity, and you can see how compressed the dural sac is.
Here's a dural
there,
sac.
over there, yeah, with all the CSF displaced out of it.
How about this? Does this help you? Same thoughts?
Yeah, not a lot more.
Okay. And that's a L4, which kind of shows you what the spinal canal should look like. Does that change anything, Adam?
Well, in this one here, now this one, it does look like it's more centered perhaps on the left facet. That it is coming up and arising from that area and compressing everything away from the L4, L5 facet, which, you know, I guess is kind of cheating saying that, I think, you know, synovial cyst. But again, it's so heterogeneous, it's definitely not normal.
So what's your differential diagnosis?
I would epidural hematoma,
Okay.
some sort of hemorrhagic epidural tumor,
Okay.
and then also some sort of I'd have to again go back.
What kind of
fatty
tumor?
tumor?
What kind of tumor? Would you say in your report or no? Can you tell or no?
I would have to look up and kind of get a differential for you know, for,
So a tumor that
Things
has
like that.
bled, maybe?
yeah.
Okay. This case you already know is a hemorrhagic synovial cyst.
Yeah.
Would you think it's a complex hemorrhagic synovial cyst?
I think a complex, yeah, I think a complex synovial cyst and might be in there, and with infection, I would also think that somehow
Possible
it's got
infection.
infection. And
Now
that's
this
how
guy's had it for
around.
3 months. Let's say it's a good orthopedic surgeon who gives you clinical information. It said
Uh-huh.
3-month history of mild
So
low back pain.
infection is not gonna, infection I think would spread,
Mhm.
if it had been 3 months, so that kind of takes that out of there.
Okay. So, Doug, would you do any other imaging studies, or would you stop here? I mean, basically, I don't know. What are your thoughts? Just send it to the spine surgeon right away, or would you
Oh,
work
God,
them up?
no, they're terrible, they just want to operate.
They're just going to operate, yeah. Never send them to the spine surgeon to get an operation.
Talk to Aetna.
Huh?
Talk to Aetna.
Talk to Aetna? Yeah.
Give them therapy.
Actually, I think it was Blue Cross Blue Shield. They don't give you much
Yeah,
hassle.
Yeah.
So this in this patient, I'm not sure what it was. So I sent it. I've never seen a complex hemorrhagic synovial cyst in my life, and I looked it up. It used to be you'd have to do PubMed or look up books, but now everything's Googled. So I Googled it, and then I also EJBJS, which is what I use. And there's only been like 20 documented cases in the literature of complex synovial cysts and descriptions of them. And I have the article if you guys want it, but it's not really that helpful.
So you think this is a cyst?
Complex.
That's absolute-
I didn't know what it was when I was going into the
You think
surgery.
it ruptured, and that's what the MRI signal is below the disc level, because it looks like.
Okay, well let me do these in steps because it's fun to doing it in steps. So I take them to the OR, and I had 3 neurosurgeons look at it. One neurosurgeon just said, "That looks ugly." The other neurosurgeon said, "I have no idea what that is." And the third one says, "Wow." And I was like, "Well, can one of you guys be available just in case this is intrathecal, if it's complicated, it's difficult?" And Hugo said, "Yeah." We said, "We're both available." So okay, so we do the case, and I was planning on doing a 3-level laminectomy. So the difference between what I usually do and a laminectomy is you cut on either side of the lamina and you lift it off, and that's the safest way to decompress the spinal canal because it's indirect, and you don't push towards it, and then you're looking at the whole tumor, whatever it is. So I did that, and then we looked at it, and then I called Hugo in. And he's like, "What is that?" It was like this big black thing. So we're like, "Oh, we're worried it was an AVM." So we started teasing the dura. And it looked like blood to us. We just see with our eyes. It looked totally like blood. And then we peeled off all the blood, and there's still some material there. So I went above and below, and I found the plane, and I peeled everything off that I could, and then I sent it to pathology. So it's a typical thing. It's like, what is this?
Okay.
And so that's where we were. Now, post-op, it was just a weird case. I wasn't sure if maybe I didn't get it all. Like I didn't feel like there was as big as what it looked like on the MRI scan. So I ordered a post-op MRI. So here's the post-op MRI at him.
So you can see the surgical defect.
Clinically, the guy says I feel fine,
Mhm.
but he was never really that symptomatic in the first
You
place.
just have pain before surgery.
Severe back pain, but not terrible. He was walking around. He says post-op, he's like, I feel fine. He had a big incision, so just in general, he's doing pretty well.
Now this is the very first one you showed us, or this is the second?
This is the second one. This is a tumor
The
now.
second one. So
Yeah.
this is the guy with the
65-year-old
atrophy
man, yeah.
keyboard. I've got this is my new laser pointer.
Okay.
All right.
Check it out.
So
All right.
5, 4, 3, 2. So you can see that. Well, here's actually 1. So this is the spinous process of 1, and then from 1 down to 4, there's your laminar defect. This is a T1 again because you can see the CSF is dark. I'm not still enough to use this thing, but posteriorly here you can see there's nice epidural fat there. There's nice epidural fat there, and that's all been removed. So all this is
What is that?
post-op tissue.
Okay.
It's,
Let me give you some more images,
Okay.
Adam.
all right, so now this is a stir, which is short tau inversion recovery. It's the same thing as a T2 weighted signal with the CSF being bright, but you can see the subcutaneous fat. I wish I could keep this thing stiller.
I
for you,
can
but
I can
anyway.
I can help you too.
Okay, so the subcutaneous fat
Uh-huh.
is dark, so
Uh-huh.
it's fat saturated. So the only thing that should be bright is water.
What is all this stuff?
And that is just it's whatever tissue there is left in the, you
There's
know,
nothing-
the muscle, the paraspinous muscle.
That's
the
paraspinous muscle?
paraspinous muscle, the fat and
Okay.
you know, inflammatory
I
tissue.
have only one question. Is it out?
As best I can tell, yes.
Okay.
But you know.
How about here? Did I
Alright,
get it out? Did I get it all out?
Well, I don't know what this stuff is. You know, this is new and different, so it looks like it is out, but you know, because this is bigger.
Yeah,
than
but
what was there
I need
before.
to know.
I can't tell. I mean,
All right.
That's just it. You know,
All right.
But the interesting thing, this is having mass effect.
It is, isn't
that
it?
Post-operative tissue is still having mass effect on the spine, like there.
That's in the dead center where the tumor was.
Yeah, so there is still mass effect there. Where
There's
it's
still
so
mass
down.
effect, and then
then
here's
there's
just
not.
above.
Yeah.
So let me tell you. I went back. I saw this. Like, what is that? I think it's gone. I showed Hugo. He's like, that looks alright. And then I called you,